Hi, I'm Dr. David Light. I'm a partner at Nibra Plastic Surgery and a board member of breastreconstruction.org. And we're going to be doing a live tonight with myself, Dr. Alexis Hazen, Anna Crollman, and Morgan Hare from the AIRS Foundation. And give me just a second as we are just getting logged in here. We're going to be covering a number of different topics tonight. There's going to be two surgeons, myself and Dr. Hazen, on, who are questions. And then we also have Anna, who is a breast cancer survivor. She's a blogger. She's an exceptional person. I have Morgan on with me now. Welcome, Morgan.
Thank you.
Have Anna joining in just a second. Sorry, everyone. This is the first time, although I have done many Instagram lives, this is the first time I've actually moderated. So give me a pass for the first one. But Anna has done even more than I have, and she's on, so I feel much better about the entire situation.
Well, some experience. Right. Yes, thank you.
That's right.
Thank you. All of my favorites in one place. In my bra, breastreconstruction.org and AIRS. Yay.
Awesome.
Yay.
So we're just waiting for Dr. Hazen to join us. But in the meantime, I'll tell you a little bit about breastreconstruction.org. The title, it actually started as a website that our practice created to basically educate patients on options for breast reconstruction. And it is now developed into a nonprofit with the mission to improve breast reconstruction outcomes for people from every background at every stage by empowering them with tools and resources they need to make informed decisions. And so our mission aligns very nicely with the AIRS Foundation and with Anna's as well. And so the purpose tonight is to basically educate, answer questions, touch on a number of topics that I think will be helpful for those who have either been through a cancer diagnosis, are currently going through one, or a genetic diagnosis as well. And so, Anna, why don't you, while we're waiting for Dr. Hazen to join, why don't you tell us a little bit more about yourself? Anna's paused there a little bit.
Did we lose her?
Hold on, bring her back. Morgan, why don't you jump in and tell us a little bit about the AIRS Foundation?
Well, there's
okay.
Anna, she's back.
I think I'm back. Sorry, it kicked me off for a second. I am back. So yes, thank you for that introduction of the breastreconstruction.org. So I am a content creator. This summer will be 9-year breast cancer survivor and going into my 6th breast reconstruction revision surgery next week at your practice with Dr. Israeli. And I am an ambassador for AIRS. So we will dig into Morgan will share more about what the AIRS Foundation does, but it's really an honor for me to be able to share my story and educate others on breast reconstruction, on mental health as it relates to reconstruction, mastectomy, surgery, as well as just patient advocacy in general related to breast cancer and women's health.
Amazing. Amazing. Morgan, can you tell us a little bit about what AIRS is, the Alliance in Reconstructive Surgery, and sort of what the purpose of the organization is?
The real purpose of the organization is to be able to educate women about their reconstruction options or nipple tattooing. And if they can't meet their copays or have no insurance, we help pay for their reconstructive surgery or nipple tattooing. We've helped women in over 40 states and Puerto Rico. So we're really national in terms of really helping women, no matter where they are in the country, with reconstructive surgery.
Amazing. Yeah, we definitely need resources like yours to get the word out and to help those that often fall through the cracks a little bit, that need a little bit more help making it through the process. You know, when you have a diagnosis of a genetic mutation or breast cancer, it's completely overwhelming, changes your entire life. And sometimes there's a support system there, and sometimes there's one that isn't quite adequate. And sometimes you don't have any family or friends that have been through it, and finding, you know, someone to help you along the way. It's very much a sisterhood, and you need that support to sort of guide you along the way. So thank you for all you do, both of you.
Yeah.
I'm hoping that this is Dr. Hazen.
Right.
I saw she commented. We were trying to get her in. It is a little tricky how to request. Oh,
there
yay!
She is. Beautiful.
Yay.
Welcome, Dr. Hazen. Can you hear us? Dr. Hazen?
And there will always be technical difficulties,
okay.
right?
All right? No problem. Anna,
we'll wait a second for her to join.
Anna, why don't you tell us a little bit about your story? Because you're a 9-year survivor. You've had multiple surgeries, revisions, and so I think that your experience is extremely valuable. So if you wouldn't mind sharing with us, that'd be amazing.
Yeah, absolutely. So, I mean, I think one thing that Ayers and I talk about a lot is that there is quite a misconception that breast reconstruction, particularly after a mastectomy, is a one and done type of surgery. And while, you know, immediate direct to implant or a deep flap from the beginning, you know, is a possibility for some candidates, it was not for me. My cancer was quite aggressive. I was triple positive and 27 when I was diagnosed, and also wanted to try and have a family after cancer. And so we instead prioritized fertility preservation, which meant surgery first to allow me more time before chemo. So I had a single mastectomy on one side with a delayed reconstruction. Later, after chemotherapy, went back and had a prophylactic mastectomy on the other side. And then in the 8 years since, it's been quite a few reconstructions. It turned out, you know, that I also ended up having a bleeding disorder, which led to multiple hematomas and some disfiguration of scarring. And so I think it's just so helpful for people to know, one, what their options are, because I think at the time in 2015, what I was maybe given as my options were not as broad as maybe now I would find out. Now I interview many surgeons, and that's how I ended up with Dr. Israeli. But at the beginning, I didn't even get a second opinion, which I think was a downside to my initial outcome and decisions and things like that. So I've definitely gone back in for multiple reconstructions, and there's both the physical decision of going back into surgery and going under, but also the mental and psychological impact of that, of am I in a space where I can cope with another recovery, a setback on my exercise routine? You know, I have a young family, so what's caring for my children and traveling? There's so many factors for women, finances.
Right.
So I feel very lucky to be where I am now and to have the options that I've had and be able to have some amazing doctors along the way. But unfortunately, there's still things that need to be fixed. And, you know, there's always the what ifs, like, would it have been different if I had done things differently 8 years ago? And I'll never know. Right.
Yeah. And you can't look back. I mean, that will drive you crazy. And to your point, you know, you had the diagnosis, you were concerned about fertility, different things at that moment took different priorities.
Exactly.
And, you know, I think that organizations like Ayers and breastreconstruction.org, they're very valuable because it gives you a lot of information at your fingertips immediately. And so you can go home, you have your consult, peruse through the sites, you know, get on, contact the organization, speak to other patients. There's a lot of resources that are offered. And that is so valuable when you're trying to make a decision that's life-changing in the middle of, in the matter of days.
Right.
And so, you know, you really have to, and it's so difficult for patients. You know, I can't imagine being in that situation, trying to process everything that not only I'm telling them, but that the breast surgeon, the surgical oncologist, the medical oncologist, the radiation oncologist. I mean, it's just a tremendous amount of information to try and process in a very short period of time. And having resources that you can actually go home and sort of, you know, read through at your own pace so that you know that you're comprehending what these doctors just told you are, you know, I think are very valuable.
I think the important part of the reason for looking at our sites is there's so much misinformation out there. You know, you look and you see Dr. Google and it tells you one thing, but that's not necessarily true. So going to breastreconstruction.org or the airsfoundation.org, you know you're going to find information that's real.
Right. And it also opens your eyes to the options. You know, Anna, you just touched on that. And, you know, thankfully in the last 20 years, breast reconstruction options have expanded. Techniques have gotten so much better. We are now, you know, doing procedures to improve, decrease the rates of lymphedema or treat lymphedema. We're doing procedures to increase sensation to the reconstructed breast. We're offering natural tissue options, implant options, where if, you know, you went back 30 years, you know, probably 95% of patients all got a under the muscle tissue expander breast reconstruction. And so things have definitely improved. Now, not every surgeon will offer every single option. And so, you know, these quality sites that offer quality information that are vetted by, you know, medical professionals, whether it be breastreconstruction.org or AIRS or the ASPS site, you know, they're valuable because if you walked into someone's office and all you heard about was a tissue expander, but, you know, you wanted to see what else was out there, that will sort of prompt you to ask questions. What about this? What about this? You know, the idea of using an implant or using my own tissue really sort of makes sense for me. I want a shorter recovery, so I'm going to use an implant. I don't want an implant, so I'm going to use a natural tissue. Whatever the reason, unless you know to ask those questions and possibly seek a second opinion, you may not get the procedure that you want the first time around. And we're fortunate that we're in a major metropolitan area, but even just a few hours outside of New York City or any major city, you know, the number of doctors decrease, the number of specialists decrease. And so it's definitely important for patients to know their options. And in this day and age, you know, sometimes traveling for care, like you're about to do,
like me,
you know, it is an option. It's definitely an option.
I love, you know, what you touched on, and like that my son is joining for just a sec. You don't know what you don't know, right? So if you don't know that, you know, tissue, like using your own tissue for a reconstruction or a flap surgery is an option, you don't even know to ask for that. And I know you have a video that was just talking about a thin patient having a deep flap surgery. When I had that conversation with my surgeon, you know, in 2015, the understanding was that if you didn't have a lot of tissue or fat at the time, that was not an option for you. And so it's so interesting as well. Like you said, procedures have changed so much in the years, and to be able to really be open to utilizing or taking advantage of that. I mean, for me, I'm going from an under the muscle surgery to an over the muscle surgery because at the time, again, when I had surgery, under the muscle was the norm. There were very few doctors doing over the muscle and those that were more experimental. So I think, like you said, so important to talk about kind of like what you don't know and ask those questions.
Dr. Hazen, are you with us?
I am.
Welcome.
I had technical issues. Sorry.
No problem. Sorry about the technical issues. Can you tell us a little bit about yourself?
Sure.
And then we'll jump into some questions?
Yeah, absolutely. So I'm a trained plastic surgeon and microsurgeon. I did all my training at NYU, and then my first part of my career was at Bellevue and NYU. I did a lot of breast reconstruction, a lot of microsurgical breast reconstruction, and got involved with AIRS. Oh gosh, Morgan, how long ago? I don't know.
8 years ago. A long time
ago. But I'm very passionate about it and really try to take a holistic approach with my patients. And I now see a lot of women who've had reconstruction years ago and want a revision of some sort or want to change things. And so I do a lot of that. And I do, like Anna was talking about, I approach it from over the muscle, under the muscle. I do a lot of fat grafting. I do, muscle flaps and muscle sparing flaps. And I just think it's so important for people to know all their options and to get informed about it. And I think, this is a great resource. And patients are a great resource, talking to somebody who's been through it. And I've found that, it's such a warm and loving community, breast cancer survivors, and that people are really willing to lend a hand and give their stories and help give information.
Yeah, our practice has something called the Sisterhood of Support. And it's amazing how we have patients that they'll come for follow-ups years later and they're, I haven't gotten a call to speak to a patient in a while, just know I'm still there. I'm happy to help. I'm happy to speak to, future patients. And so the community and the sisterhood is really, it's amazing. And I think we have to harness that and make sure that it's available to patients, because it makes a world of difference to connect with someone who's been through it if you don't have someone close to you that, you can turn to already.
And we have a number of advocates. And so if we agree to help someone with their surgery, we assign an advocate to them. And most of our advocates are breast cancer survivors. And so many of these women have no support system, none.
Yeah.
So the fact that there's somebody, and they don't give advice, they're just really there to be an ear and listen, because they don't have anybody else to talk to.
Yeah.
If you're part of the underserved population, you are underserved.
Yeah, absolutely. Dr. Hazen, how do you approach new breast cancer consults, reconstruction consults? There's so many options out there. There's oncoplastic techniques, there's implant techniques, natural tissue. When someone walks in, they're not sure if they're going to have a lumpectomy or a mastectomy. How do you approach the consult?
Well, on the one hand, you want to kind of offer all the options. On the other hand, you don't want to overwhelm somebody. And if they've just gotten the cancer diagnosis, to throw out like every single possible option, because there are a lot for most people, it can just be too much. And then I think the brain shuts down and you are a little bit lost. Mm-hmm. So what I try to do is just get a snapshot of sort of where they're coming from and what their biggest concerns are in that moment, and kind of start from there. And a lot of times people do have a general instinct about what they do or don't want. And for some people, it's they want to get back to work as soon as possible, or they have children and they need to take care of them, and they want the shortest recovery possible. For other people, something like sensation might be the most important thing. They want to maintain sensation. So, doing something like a lumpectomy, as much of a breast sparing procedure might be the most appealing. So I think for me, the biggest thing is kind of figuring out where they are, what their goals are to the extent that they have them, and then direct the conversation there. And then later we can come back and offer other options if they just want to know what's available. And then I think always having at least 2 conversations, and saying like, we don't have to decide anything today.
Yeah.
And this is something you should think about, talk about with other people, see how it lies. And every now and then somebody is just so overwhelmed, they choose not to do anything right at the beginning. Mm-hmm. And then later they make a decision about reconstruction. And I think that's totally reasonable. You have to kind of meet people where they are.
Exactly. Yeah, I mean, we're in a support role, an education role, like a guidance role, trying to walk them through this. I allow the physical exam to sort of guide too.
Yeah.
I always tell patients, there's 50 options. After I examine you, we're going to narrow those down to, probably 3 or 4 that are really ideal for you. And, they'll hit each of the categories, and then, reviewing the advantages and disadvantages to each. Sometimes we'll say something or show them a before and after picture that really strikes them.
Yeah.
Sometimes they'll hear something about having to get an MRI for implants as part of their surveillance, and that triggers them. They don't want to have MRIs. Or sometimes I'll show them a before and after of a deep flap, and they'll see the scar on the abdomen, and that's not appealing to them. And so I think there's also certain triggers as we're going through the consult that will push them in one direction or another. But at the end, there's plenty of times where it's, just so overwhelming that it takes another visit or 2 to sort of solidify a plan. And that's always okay.
Yeah, absolutely.
What about,
Sorry.
what's that? Go ahead, Anna.
I was just going to say, I love that you both mentioned, that reconstruction or revisions are possible later on as well. I think as a patient, there's a lot of pressure to make all those decisions up front. And I think you're right. I mean, giving yourself some space to say, hey, I can do reconstruction later. I can spend some time thinking about what I want, healing from some of the traumatic mental health sides of a cancer diagnosis as well, can help you maybe frame that discussion in a clearer light or have a different perspective, after maybe 6 months or so. And then just what came to mind is those little quizzes that used to be in magazines, or probably still are, where it's like, how do you feel about abdomen scars? Yes or no? I'm imagining like we need this cheat sheet for breast reconstruction, because there truly are so many options. Do you have enough fat on your body for XYZ? Do you want implants? Like, I think we really need to create this.
But the techniques have gotten so much better, and the sort of options, there's techniques to increase, there's fat grafting to increase the volume of a deep flap, there's surgically delayed extended deep flaps, there's stack flaps, there's hybrid flaps. So patients that used to fit into a category and used to be told, no, you can't have this, well, now they can. So that it's a plus and a minus, because you still have so many options to sort of wade through. But the great thing is you still have all of those options. And of course, sometimes the option is reconstruction is not for me. And that's totally fine as well. There are women who will opt to, have an aesthetic flat closure, or they'll opt to do a Goldilocks procedure just because they're just not interested in a reconstruction, and it's not something that's important to them right now, and they want to go in a different direction. And of course we support that as well. I know our talks are always heavily on breast reconstruction, but there is an option of not having a reconstruction.
Yeah. How common is that for both of your practices? I know somebody in the chat had said, that they had a radical mastectomy and we're flat now, and we're going with that. In this case, I think, maybe I'm picking up that maybe there was some regret about that or feelings about that. How often do you have someone come in and kind of say from the get-go, I want an aesthetic flat closure, or, be knowledgeable about staying flat as an option?
I mean, I've noticed an uptick in the last probably 5 to 7 years, mostly because I think that, there's been more talk about it. There's more information on the internet. I think a lot of people felt the need to just move on with the reconstruction because that's just what you did. But knowing that other women don't choose that and they choose to go flat sort of puts that idea in your head, and like, well, this actually sounds like it's for me. Have you noticed the same thing, Dr.?
I have, and I also I do a lot of gender affirming surgery, and so I think folks that I either identify as trans or non-binary tend to seek me out to do their reconstruction, and so I've done more and more of those, and then we'll also at the same time do a nipple and areola reconstruction. It's certainly not the most common, but I have seen more and more of that. And for the people who choose that, I have to say they are very happy. And they've thought about it a lot, and it's a quicker road to getting back to activity. And for people who've always had, either dysphoria about their chest or are very athletic and really never wanted to have breasts, it is a minority of people, but it's very empowering for them to be able to, make that choice and have that be, and it is a reconstruction. I mean, approach it, we approach the incisions, the look, everything, it's not just a removal, it's also a reconstruction.
Is there an age differentiation that you're seeing more young people or older people who decide to go flat?
In my practice, I would say more older.
I would agree, but I think because of increased exposure, there are younger women who I think are more accepting of it now, just because there's more talk about it. I did see on the chat here that, someone opted to go flat and is not happy with it. There are options. Yeah. So even one of my favorite things about breast reconstruction is there's almost always an option to make a change and make it better. It may take more than one step, but if you chose to be flat and you don't want to be flat, there are options. If you chose to have an implant and you don't want an implant anymore, there are options. And so there's you're never stuck. There's never a closed door. You should always seek out, a consultation and advice if you're unhappy, because, more than likely there'll be an option for you.
What's interesting to me too is just recently we've had 2 men apply to us for breast reconstruction, and that's new in all the years we've been doing this. Are you both seeing more men who have breast cancer who are wanting some form of reconstruction?
The rate of male breast cancer is so low compared to women that we just see so few men. But, probably about a year ago, I went through a 6 to 8 week period where I operated on 3 men doing chest closures for male breast cancer. And, they were all very interested in making sure that the closure was neat. One of them actually just had a 3D nipple tattoo a couple of weeks ago. And so, the desire for reconstruction is not, just for women, men are out there too.
I think
Interesting to us.
Yeah, it's a really good point. And that's an area where definitely education that you can do a nipple and areolar reconstruction, either with 3D tattooing or with a local flap or a combination of the two. And, if no one talks about it, people don't know, you're not clairvoyant about reconstruction.
Right.
So I think it's a really good point. And I think it can be just like everybody, it can make you feel whole again in a way that, cancer can take away from you, but this can put you back together.
Yeah.
I love that.
Agreed, very much so. So,
And go ahead.
You had mentioned that you've had multiple surgeries already, and for different reasons. So certainly there sounded like there were some bumps along the way. I have a lot of patients that will come in and say, I just want surgery in one step. And, I just want a quote unquote one and done, which, many times can be achieved. It can be achieved with an implant reconstruction. It can be achieved with an autologous reconstruction. I do plenty of patients that have had deep flaps it's just one procedure and they're done, especially in nipple sparing. But I always find it challenging because it's never something that I want to promise. Anna, how was that approached with you? And then Dr. Hazen, if you could follow up with, how do you approach that with patients when they're requesting a quote unquote one and done? Are you comfortable with that, or do you advise otherwise?
Yeah, I mean, I think that, trying to look back now, it's been so long, but I do remember having a very clear discussion with my surgeon and the nurse at the time that, this is likely going to take a while. It's not going to be a one surgery and done. Now, I think, we talked about at the top of, there is this mental piece that I don't think I was prepared for the mental impact of years of surgery. So it's like, to Dr. what Hazen was saying, your first appointment, you're nodding your head. Yeah, okay, I get it. Multiple surgeries. Okay, I'm in it for the long haul, but you don't really realize what the impact of that is on your life. And so I think it has taken me this many years to really want to spend that time in my life dedicated to another surgery. So there's been times when I say, oh, I had a revision. Oh, I'm not too happy. Right after my implant transfer, I had got the expanders out, I got the implants in, and immediately I didn't like some things. Once they settled, the areas where it had hematoma, there was extra skin, there was just issues. But emotionally, I was not ready to go back into surgery. I mean, I was distraught. And so my surgeon was really like, you know what, why don't you, I know you're unhappy, but why don't you sit with this for 6 months? And as the months went on, I realized, I don't really want to be in surgery right now. I just want to live my life.
Yep.
And a couple years passed and it was like, okay, this really is bothering me. Now I want to do something. So I do feel like in a sense, I was prepared with the knowledge. I wasn't prepared for the impact on life, I think. And I don't know if that's something any provider can do, but Dr. Hazen, I'm curious your perspective of how you approach that with your patients.
So I think sometimes people really are a good candidate for a single stage operation. But it's like the stars have to align perfectly and everything has to be perfect.
Right.
And the other thing is the oncologic breast surgeon has to be someone that, you know, I've worked with a lot, and I know that they can do their part so that I can do my part.
Right.
And usually the best candidates for, you know, like a direct implant are people who are a little bit bigger than they want to be. They're willing to go a little bit smaller so I can remove a little bit of skin to give a little bit of a lift, and are starting out fairly symmetric and have a relatively low BMI and have no health problems,
Yeah.
like, you know, so in other words, they have to heal perfectly. And that happen actually, you know, honestly, that happens in a lot of our patients. They heal like perfectly. So in those patients, I would offer it. And then I always offer, you know, down the road, if they wanted a revision or if it doesn't turn out exactly how we want, you know, we could adjust things. And then I think, you know, your story, Anna, is it's very well, I mean, thanks for sharing, but it's also very typical of people in that, you know, you tire of this and you don't want your life to be about having surgery and recovery. And at some point, you just want to get back to your normal life. So I think having a good relationship with your surgeon and knowing that they'll be there for you when you decide that you want to do something, and having confidence that they'll be able to, you know, achieve your goals with you, I think makes that off period a little bit easier.
Yeah.
And I think people are incredibly resilient and are able to kind of have acceptance about things that are not perfect and move on with their lives. And then I think it's empowering to know that, you know, when you're ready, something can be done. And it's very rare that we can't improve the appearance of things and the functionality.
Yeah.
We can almost always do something, even if it's small.
Right.
And I
Yeah.
think
And I,
that's it. Oh,
no,
sorry.
go ahead.
I was
Go
just
ahead.
going to say, I know a couple of people in the chat had kind of said, oh, my doctor said I can only do this because of this option. I mean, I think having spoken to both of you, having now planning to have a surgery in your practice, if you are not hearing the answer that you want from a surgeon, you need to talk to another surgeon, right? Because what
Great.
I'm hearing from both of you all is that there should be options. And if your surgeon is saying, no, you have no options, you have to live with this, it looks this way, or sorry, you're fine, you're healed, whatever, you don't have cancer, that should not be okay. And so I just wanted to really drive that home because I think both of you spoke to that. And it's so important, I think, for those in the chat to just know, like, there are surgeons out there that will listen to you if you're not having that
Right.
experience now.
But I think the other thing that's really important is when you interview the surgeon is how often do they do this surgery? I mean, you don't want to go to somebody who does it twice a year because you're not gonna, that's
Yeah.
not what you want.
And
So
I think you bring up a good point, Morgan. I think that's sometimes, you know, in the relationship between the surgeon and the patient, the surgeon may run out of options, or they may have tried something and not had the success that they expected. And
Yeah.
so there becomes a hesitation, and there's nothing wrong with that. That's actually the surgeon saying, I'm out of my comfort zone.
Yeah.
I'm not going to just do something
Right.
for the sake of doing it.
Great point.
It may not be them saying, go and see someone else and leave me, but, you know, it's for the patient to sort of interpret, okay, I've been under this person's care, and this is sort of where it's going to stop. If I'm not happy, never a problem to ask for a second opinion. You know, when I meet a new patient, if they want to have a second opinion, I'll give them 2 or 3 names of people that I trust, that I would be happy with them going to, for them to, you know, go. Because I think that if you hear the same thing twice, it's comforting. And
Absolutely.
getting back to the staged, I always tell patients that the second, third, fourth stage is up to you. If you're happy after the first, we don't need to go any further. If there's things that, you know, the human body's skin is elastic, so we may put an implant or a deep flap someplace, but where it heals 3 months later may be a little bit different. There may be a little bit of an adjustment that can be made, and each patient is also different in their sort of aesthetic, you know, expectations. There are times where my OCD kicks in and I see something that I want to adjust and fix because I know it'll make the reconstruction look better. And the patient's like, leave me alone. I'm totally happy. I'm like done here, no more.
Yeah, you're driving the bus.
Yeah, exactly. I'm like, okay,
Yeah.
fine. You're the boss, not me. But there's so many factors that will drive whether there's a second or third procedure. But I think it's important to leave that door open. Anyone who says, I really just want to have, anyone who guarantees it will happen in just one surgery, or anyone who demands that it will happen in just one surgery, whether it's from the doctor side or the patient side, it makes expectations a little bit more difficult, and better to leave that door open is I think the more honest approach. Okay, so I think we're going to start to move to maybe some of the question and answer section.
Awesome. So let us know in the chat, guys, if there's questions that you have specifically for either doctor, for Morgan, about ears, for me, from the patient side. We can answer your questions. I think some that have come through, we did answer. We did have one person, Dr. Hazen, that said she had a fat transfer to her breast as a trans woman and went from an A to a B and almost a C. So that's really cool. You had brought up that example, of different body types and all kinds of surgeries that you can go through as part of reconstruction.
Yeah, and I think, fat only is rare, but it's a great option for small size reconstruction. And fat transfer is just such a beautiful thing. Taking fat where you don't want it and putting it where you want it, it's magic. And it's tiny incisions, so that's easier to heal, and that the change is permanent. So if you take fat from someone's belly where they maybe have a little extra and put it in the breasts, you can get a really lovely reconstruction that's permanent.
Yeah, it's a great option as sort of an adjunct, where we're either adding volume to a reconstruction, treating little contour abnormalities. It's really a very powerful tool. I just saw a question come by that someone was curious about how radiation affects the overall reconstruction. Dr. Hazen, do you want to comment on that?
Sure. Yeah. It affects it a lot. Radiation is a very powerful tool to reduce, local recurrence of cancer, but it effectively can burn the skin and the soft tissue. So there are two different approaches. If you're going to have radiation, it's rarely people don't know, but because something is found at the time of the surgery, but often they know ahead of time. So my approach would be, I don't like to radiate soft tissue. So if I were doing a tissue reconstruction using your own tissue, I would delay it until the radiation was done, put in a tissue expander, and then let things heal. And it varies. People look so different after radiation. Some people, you can hardly tell that anything was done. And then other people, really, their skin gets very thick and firm and can even, really become like fibrotic. So then there's a waiting period. And then I would typically do the definitive treatment for reconstruction, or the stage for the breast mound after the radiation has sort of calmed down a little bit. One adjunct back to fat is fat transfer has been shown to really improve radiation damage in patients. And so sometimes that can be kind of a bridge to reconstruction and to get the tissue kind of back to normal. But people have very different approaches, and some, even institutions, have different approaches about this, and some like to get the reconstruction done and then they radiate the sort of the final reconstruction. In my hands, I haven't had as good results with that, so I don't recommend that.
Yeah, I agree. If I know I'm going to do a natural tissue reconstruction like a deep flap, my preference is to put a tissue expander in first. I usually wait about 6 months in between because radiation will cause fibrosis of the skin. It can also cause delayed edema. And so sometimes the skin actually looks like an orange peel. And you really want that to start to resolve before you go and reoperate, because the tissue just isn't as supple and malleable for us to really get a quality reconstruction. And so it can be frustrating for patients to wait that 6 months, but I always say that, this reconstruction you're going to have for a lifetime. So cutting the corner by a month or two, if it's going to affect your final outcome, it's not, not worth it. Don't think about it in terms of this year. Think about it in terms of the next, multiple decades.
Totally agree.
And the other thing to remember with radiation is radiation with implants increases the chance of capsular contracture, which is essentially the scar tissue around it. And so you can have an implant reconstruction with capsular contracture, but a lot of surgeons will opt to move you into an autologous natural tissue reconstruction to avoid the risk of capsular contracture. Switching patients from implants to a natural tissue reconstruction is a fairly common procedure in our practice because we manage a lot of issues with implants, whether it's radiation issues or pectoral animation from having implants under the muscle, switch them to over the muscle. So there's definitely options out there for all of these issues.
I'm going to jump in real fast on the under the muscle versus over, since that's what I'm having next week. And me and Dr. Israeli did a live on that last week. And so kind of just to answer, why would you do that? I mean, I think many of my revisions over the years were to address what I thought were very cosmetic issues on the outside. And so what Dr. Israeli and I have kind of figured out is, no, they're actually being caused because my implant is underneath the muscle and it's causing animation. Right. It's causing the scars to now be concave and go in. And I kept thinking, oh no, the fat grafting is just going away. And so, for some people we heard from last week, they're dealing with a lot of pain. They're dealing with neck and back pain related to that. I've been so lucky I have not had pain over the years. So it's more just the physical indentation. I also have a capsular issue on one side. So I think I'm looking forward to it having a different feel, being able to move my muscles a little bit more freely. And I don't know if either of you would add anything to that as well in terms of the pros or cons to switching.
I think it's been a game changer. It's kind of it's almost like, it's a thought change. So we just had a knee jerk that the implants went underneath the muscle, and in the case of breast reconstruction. And I think that, it's very successful in a lot of cases, obviously. But when you do have an animation deformity, and when you have, which is when the muscle contracts over the implant, it's not only, doesn't look attractive to you, but it doesn't feel good. And you can feel the implant shifting laterally, and it's uncomfortable. And then often the muscle will kind of go into spasm, and it contracts, constantly. You were talking about neck and back pain, and that's, why it's related. And so I think the whole concept of being able to do a reconstruction where you don't disrupt the muscle is brilliant. And a lot of people are candidate for that. And in the patients who are candidates, it looks great. It's less morbid. Then your pec muscle is completely intact. So, do as many chest presses on the machines as you want, and push-ups. And so I think it's really been great. I don't know. What do you think about it, Dr. Light?
Yeah, I agree. I mean, I haven't put an implant under the muscle in, probably 8 or 9 years. And now I'm switching a lot of patients from under the muscle to over the muscle.
Yeah.
Studies have shown that there's increased pain under the muscle, not only immediately after surgery, because you're literally releasing the muscle from the bottom of the chest wall, elevating it off of the chest wall, and then sliding the implant under. But then you get this chronic discomfort from the implant constantly putting a stretch on the muscle.
Yeah.
Then, of course, the animation deformity, which especially in active women, like it's very common for a very active woman. She's in the gym, you're wearing tank tops and whatnot and doing certain exercises. And every time that pectoralis muscle contracts, there's movement. And that's very, upsetting and uncomfortable for the patient. And it's highly successful to switch it to over the muscle. The only disadvantage to going over the muscle is depending on how thick the soft tissue is, meaning how thick the skin is and how much fat is underneath the skin, you may be at a little bit of an increased risk for rippling, seeing some rippling at the top of the breast. but that can always be treated with fat grafting at a secondary procedure. And so, most women who come with issues with the implant rippling, they would trade it for rippling in a heartbeat to make the discomfort go away and to make that animation go away. So I think it's an excellent option, and whatever downsides may come with it are treatable. And so I always encourage patients to make the switch. Let's see, we have another question. How can people find surgeons where they live? And so that's, I think that, you're going to start, if you have a cancer diagnosis, you're going to start within, with a radiologist who's then going to probably send you to a breast surgeon, and then the breast surgeon is going to send you to a plastic surgeon, is usually the way it works. So there you'll sort of already be set on a path. Now there's always, like we've talked about already, you can always ask for a second opinion, whether it's from the breast surgeon or from the plastic surgeon. And I think any quality breast or plastic surgeon would be totally comfortable with that. If they're not, that's a little bit of a red flag. But I think what's even more interesting is people who are looking for a revision to their reconstruction or have a genetic mutation, who have time on their hand and may not have been sort of placed on this pathway, that the options are a little bit more open. And so I think the internet and social media, for all of its downsides, are very helpful when it comes to this.
We do have a list of surgeons on our website, so you could always check that out. And
I'm proud to be one of them.
Yes, you are. So what we're working on now is we're really sort of reaching out to more surgeons around the country so we could expand our list, and we vet them. We really want to make sure that if we're recommending somebody, again, they do it often, they can do microsurgery, and they're knowledgeable. So if you're on our list, you've been vetted to make sure that you can offer the best options to people. And again, we're trying to really expand that because there's a lot of areas of the country where there's no one.
And
so important.
Anna, can you comment on that, because you've been through this process?
I think I wish that I had known heirs, Morgan, back a few years ago when I was going through my first revision, because it was very much, part of it was social media, talking to other women across the country who have gone to different surgeons and getting their insight. And another thing I recommend sometimes is, if you connect with a surgeon on social media, but you're not sure if you'll be able to travel, I think there's also value in having consults with people around the country. So I've had consults with surgeons, paid the copay or the fee to just say, hey, what do you think about this? Does this seem like a logical approach? And actually, that's how Dr. Israeli and I started talking this time around. I had worked with my last surgeon locally. He retired. So then I was left with, okay, I can go to someone new in your practice who I don't know. I interviewed another doctor that my oncologist recommended. And then I said, I know this Dr. Israeli guy from Ayers. Maybe I should just talk to him. And so then I really went through interviews with all of these people. And at the end, it was like, okay, now who feels right? Now who's giving me the options that I feel most comfortable with? But I would say definitely just if you have a little bit of time, and even if you don't, I say do it fast if you can, but interview surgeons as if you were interviewing someone to take care of your children if you have children. Like, this is a big surgery to your body. You get to ask the questions. You get to kind of really feel comfortable. So Morgan, I'm so glad we have that list of surgeons, because now I'm going to use that. People reach out to me all the time. Do you know somebody in Texas? Do you know somebody here? So yeah, I'm always kind of searching for new surgeons.
Yeah, if you live in upstate, even Texas, you're near the Oklahoma border. There's no one. So people will travel the 2 hours or 3 hours down to Dallas because we have a number of really good surgeons here, but no one up there is going to recommend anyone to you. That's the problem.
Oh, breastreconstruction.org has options too.
Right.
And I will say, I'm now navigating the situation of traveling out of state. So if people have questions of what that's been like, I know we don't have time now, but, please send me a message or DM. I'm glad to share what that's been like navigating it's not been as awful as I was expecting. So, there's some hangups and logistics, but it's been relatively smooth. So I think that's helpful for people to know too, that many times traveling out of state, yes, it is going to be a little bit more expensive just in terms of usually being out of network for your provider. But it's just, knowing what your options are is important.
Absolutely. So I think we're going to wrap things up. I just wanted to thank everyone for spending some time with us tonight and sharing a lot of really critical and important information. We'll definitely have to do this again. We got so many questions and such a great response that I think it just speaks to, the need for talks like these and the need to keep doing it. So thank you all so much for joining, and we'll see you soon.
Thank you all.
Thank
Good night.
you.
Good night.
Bye. Bye-bye. Have a good night.